So good afternoon to all of you, or good morning or good evening, depending on where you are. Welcome to this year's roundtable. Of course, it's more of a probably around the desk table because we're all separated as compared to the last pathology day roundtable that we had. So we have a panel of distinguished speakers, and I will introduce you to them shortly. So the topic for today is basically is to do with the topic of international sharing. And we're going to discuss the importance of international exchange of information, particularly in the context of this pandemic, and how screening, diagnosis, treatment selection, and health monitoring differs between regions. Now, we've sort of had a taste of that in this morning's sessions, but perhaps if you've just joined us, this will be of benefit to you as well. And we've learned, obviously, that in the setting of COVID-19, it's more important than ever not to place boundaries on our ability to learn from each other. I can certainly attest to that in some of the things we're doing. So just to give you a roundup of the schedule, we're going to have a discussion for about 45 minutes. In the interim, you're welcome to type in your questions in the Q&A box. It will also be very, very interesting and informative for you to tell us where you're sending your message from, so we have an idea of how far across the world people are viewing this roundtable. So without further ado, I'm going to call upon each of our distinguished speakers to introduce themselves. You may have, if you were here in the morning sessions, you may have already encountered them, but if you just joined us, I think it'll be useful for us to just recap on the speakers. So I'm going to start off first with Mr. Evangelos Kotsopoulos. Evangelos?
Thank you, Professor. I'm back from lunch and from my flu shot. I just had my influenza vaccine just now quickly. So for those who weren't here this morning, my name is Evangelos Kotsopoulos. I'm the CEO of the Sonic Healthcare Laboratories in continental Europe, particularly in Germany, and I'm based in Berlin.
Thank you very much. We'll next go on to Professor Ali Hajir.
Good morning, good afternoon, everybody. My name is Ali Hajir. I'm Professor of Immunology working at King Abdulaziz Medical City, National Guard Health Affairs in Riyadh, Saudi Arabia.
Thank you. Our next distinguished panelist is Dr. Pekka Jokelainen.
Yes, hello everyone. Thank you, Professor. So my name is Pekka Jokelainen. My background is in veterinary pathology and parasitology, and my research focus is zoonosis and One Health. I'm based in Denmark, Copenhagen, at a public health institute that also has veterinary preparedness functions. Thank you.
Thank you. Our next panelist, who probably needs no introduction, Professor Joe Martin.
Thank you, Tahir. I'm Joe. I'm the president of the Royal College of Pathologists.
Thank you. And our last panelist is Dr. Josh Wright. Dr. Josh Wright.
Hello, thank you very much for asking me to join you. I'm sorry I wasn't able to join for the morning. I'm a consultant hematologist based in Sheffield, working full-time for the NHS, and I'm currently Vice President of the British Society of Haematology for Haematology.
Thank you very much. I think I will, just to introduce myself, of course. I'm Tahir Pillay from South Africa. I'm a chemical pathologist by training, and I'm head of chemical pathology as well as the the pathology services at the University of Pretoria in South Africa. So we've heard about some of the international efforts that have been going on in various countries. In the morning session, we heard about Germany, and then we heard about Saudi Arabia and South Africa. And so I guess one of the interesting things that was mentioned was in regard to the Bundesliga. So so the question I could put to Mr. Kotsopoulos is if he knows whether there are any other settings besides sports where the program that they've implemented might be effective. And if he knows of any, or he could suggest a scenario where such an approach would be useful. Up to you.
Yes, thank you. So besides professional sports, where it's been copied to many leagues, we've had it in the basketball league here with a slightly different concept. North American sports leagues have copied it, the English Premier League. We've seen it used in settings where people come together in similar groups in certain intervals or patterns. So the Berlin Philharmonic Orchestra, for example, has adapted the concept because their training session, of course, is practice, and they meet several times per week, and then they might have a concert on a Saturday night. And after the lockdown restrictions were lifted and the concert halls were allowed to leave, at first at least a few hundred people back in, and then later sort of 40–50% of seats filled, they basically used a very similar concept of regular testing during the week and then a session a night before. Where it hasn't worked very well, we found, was when people tried to use these concepts for mass testing. So some event organizers in late summer would have loved to have large concerts back in action, rock concerts or even very large classical concerts, and said, can't we just quickly test 10–15,000 people at the gates before they all come in? And we said, well, there's a few practical limitations here that will be very difficult. So we've kept a respectful distance from these kind of concepts, let's put it politely. Where we have also seen it, Professor, was in the corporate setting, where large companies who had sent especially office-based workers home and into a home office for a relatively long period of time were thinking, how do we get them back? And we've worked with some large Swiss banks and insurers, with a large fashion group in Great Britain who had to bring back textile workers from northern Italy, designers who had spent their time in France and elsewhere, and who wanted to have advice on whether it makes sense to test or repeatedly test their staff to avoid them carrying an infection into the company where it had been, basically closed for a long time. That's a different setting than sports, where people travel right around the country every weekend. But the principal thinking behind it is basically the same. Some of it, in our minds, goes a little bit over the top. We have had requests from very large, let's say, technology companies who would have loved to have their staff tested, every 48 hours, which is a burden on testing capacity and from a medical standpoint, not really very meaningful. And so there is a bit of tension in this topic as well. And I don't think the Holy Grail has been found on how precisely to do it, but we've seen these programs evolving, and many of them, I think, work quite smoothly these days.
Yeah, interesting that. Just to follow up on that, what is the demand for serology testing been for people coming back, say, from being in lockdown? What have you found in Germany?
We've seen a peak when the test, I don't mean the rapid test, but the lab-based test became available. To be honest, there was probably a good portion of curiosity in this. Many people racing to say, well, maybe I've had the virus and I want to know whether that has a medical meaning or a consequence, obviously is a big question mark at least. And it has almost died down, I have to say. So there is, of course, the tracking of previously infected people where antibody titers are kept track of over time. But demand for antibody testing here at the moment is very, very low. Simply because unless someone is ill and needs the information for another reason, there is not very much you can do with the result at this point. So, but in those back to work programs, we've said, you need to focus on current infections. You need to focus on those people who might still be infectious right now when they come back and who obviously need to be filtered out and should be prevented from attending an event or enter your company. But antibody testing is more a curiosity part, perhaps, at this point.
That's interesting because it brings me, Prof. Martin, did you have your hand up?
Yes, I did actually.
Yes,
Sorry,
go
I was
ahead. Yeah.
trying to find the button for the hand, failing miserably. So I was just going to come back on that because Hong Kong, we heard at the International Liaison on Pathology Presidents that Hong Kong have been using PCR testing with a value over 30 and then serology testing. And if it's positive, then they regard the patient as, or the person as non-infectious. And they've been sending them home or letting them back to work. So that's been an interesting use of serology.
It's interesting because this discussion, Professor Martin, you mentioned, is very active here at the moment, also triggered by many of the virologists who are very present also in the media at the moment. This big discussion between whether we are diagnosing an infection per se, or whether we are looking for people who are infectious at a certain point in time. And because CT values are so difficult to compare, even between instruments of the same manufacturer, let alone between different platforms which are used, it is a very tricky discussion. But because of the lack of sensitivity of the antigen tests, there is a very active discussion here at the moment to say, well, the test might miss people with comparatively high CT values, but that doesn't matter because they're not going to infect anybody anymore, or not yet, of course. So it's an interesting one, which I think is evolving quite a bit further still.
Yeah, we've had similar discussions as to, because everybody's looking for the rapid test with 100% sensitivity and 100% specificity, but it probably doesn't matter if you miss a few cases, because the ones that you might miss are the ones that, where the viral load is so negligible that the person is not, it may just be maybe just free RNA that happens to be still being shed and the person is not infectious, and the PCR might come up positive, but the other tests come up negative, or, you know, that kind of thing. So yeah, we also have that discussion, but it does, I mean, the whole serology thing, and I think I want to go to Professor Hajir just to ask him about whether he sees serology fitting into a larger testing program, because if you feel that in Germany it's not of much use, you know, what is the view in Saudi Arabia, and do you see any additional tests being used to supplement it?
I must say, in Saudi Arabia, we follow what the evangelist just said in terms of the antibody test. People at the beginning thought that might be a useful tool to use, but then results were not really, were not very clear. So people seem to depend more on the PCR. I must say here that so far we don't have long term follow-up of patients in terms of serology and PCR. I'll tell you some experience that we had in our lab. There are some patients who have persistent PCR positive, even more than 14 days post symptoms. And when you look carefully at the PCR, you see that they seem to lose, for example, the S antigen, the S gene positivity, but they keep positive for N antigen, or the N protein, I mean, or the E protein. And we do not have solid data to show, apart from the neutralization assays and infectivity of these patients in vitro. We don't have that data, but we don't have the data to see whether there is a correlation between certain antibody levels and infectiousness of these people. And what is the relationship between positivity for the different genes? So what I believe we need long-term follow-up of those patients who have persistent PCR positive to see what antigens seem to persist in the PCR. And it's not just a CT value, but why do some patients seem to be negative, become negative after 2 weeks, while others persist positive, losing certain gene, mainly S antigen? My personal sort of view is that those who lose the S positivity, they are becoming non-infectious. And what you see with the N and E protein, E gene positivity is just a reflection of dead viruses, etc. To go back to the question, what is the role of antibody testing in terms of diagnostics? The basics of this viral infection is that it is acute respiratory, and you need to detect it as early as possible just to isolate those patients and to avoid sort of infection, avoid them infecting other people in the surrounding. And if you want to wait for the antibody, which will appear about 10 days after the onset of the infection, then the patient will be really, especially those with the high viral load, or we call them super spreaders. We notice them in MERS. Certain people seem to shed lots and lots and lots of virus. We don't hear that term nowadays with the SARS-CoV-2, but I believe we have seen some patients with very, very high viral load in their respiratory nasopharyngeal samples. So again, do we use the antibody assay for diagnostics? In our setting, we do not. We try to use them whenever we have a patient that shows negative PCR, but seem to describe signs and symptoms. And we try just to use it as a marker of previous infection, if you like. But to detect the acute infection, I still believe that PCR is the assay to go for.
Thank you. Yeah, so just to give you an example, in South Africa, the seroprevalence studies seem to show that more than half the population have at least antibodies to SARS-CoV-2, which is interesting. So there's been a lot of if that's accurate, if that's a reflection of how many people have actually contracted it, we've sort of slowly getting to to a possible herd immunity. But again, that's come out of the seroprevalence study. So it's still an open question of whether it's useful for surveillance or whether it's useful for okay, Mr. Kotsopoulos.
That's an interesting data point you mentioned, Professor. If it's really near 50%, we had a study published earlier this week, actually, where the Munich Medical School did a similar study for the whole population of Munich. It's a city of about 2 million people, in June. And they found a prevalence of about 0.4% through testing early, and now in the antibody study of 2%. So that tells us two things. We missed 1 in 5 when we tested right through to June, but the actual level of infections is so low that any discussion about herd immunity and others can be immediately forgotten. And this is an active city. It is close to Austria. It is close to Italy. It had lots of skiers returning in March. It's a city with a big international airport. So the assumption also is that in other parts of the country and more rural areas, the prevalence would be even lower. But it gave us these two interesting insights, and this was just, it was not a small study, it was about 5,500 people who participated, randomly selected right around the city, and we could match this quite nicely with the PCR results we had from the same zip code areas. So if it's 50% in South Africa, that would be quite interesting.
Yeah, I think it's a projection based on you know, a random sampling that's been taking place. So it's been found to be surprisingly high, and it's so the one opinion was that it may be other coronaviruses that, you know, people have been infected with in the past. But if we consider that what Professor Hajir was saying, that the antibodies appear to be quite specific and not cross-reactive, but, you know, again, it depends on what assays people are using. Dr. Wright had his hand up. Yeah.
I did. Yeah, it was just a couple of points. I think you talked a lot about persisting PCR positivity in patients. From a clinical point of view, increasing numbers of medical staff are now being tested. So you've got, you know, surgeons on pathways where they're trying to reduce COVID transfer to patients, and doctors like myself working with very immunocompromised patients who get regularly screened. And of course, we too are picking up these people who we then now really don't know what to do with them. And you, in an attempt to you know, in a well-meaning attempt to kind of make the patient safer and reduce nosocomial transmission, you kind of, the counter argument is sometimes you end up actually creating a problem in terms of knowing which people are safe. So it is very important that we try and work out exactly who are infected, you know, who is infective still. The other point was, I think there was a local study done on, this is a large trust I work in, and right at the beginning of this, we performed a seroprevalence study, and I think the seroprevalence in the staff at this hospital was about 12 or 1,300 staff were tested, so a reasonable number, was under 10%. So again, nothing like South Africa's 50. Sounds like you're well on the way to herd immunity.
Professor Mark.
So the blood transfusion service in the UK has been monitoring seroprevalence, and there's marked regional differences, and similarly in healthcare. So what Josh says is absolutely right, but some hospitals in London have had 40% positivity rates, antibody positivity rates. In healthcare workers. It varies between what type of healthcare worker you are as well. So it's interestingly, it's not A&E and it's not ITU. It was actually the non-COVID wards that had higher antibody positives. So the presumption is that it was the PPE was better and awareness was better in the very acute levels. The other interesting data came from, sorry, that was seroprevalence studies of healthcare workers. The other one was from the British Blood Transfusion Service, where in London, there was a very steep age correlation with seroprevalence, with the 18 to 24-year-olds, or the 18 to 25-year-olds having a seroprevalence of up to, I think it was up to 27%. And then marked decreases across the age range. And that was, London was one of the higher seroprevalent areas. We've got other, lots of the Siren study and lots of other seroprevalence studies going on at a public health level, but we had very, very high seroprevalence levels in some areas, you know, vanishingly small in others. And it is changing as we've got the virus going in different areas of the country now in the UK. So it was very strong in London to start with, and now it's northwest and northeast. So Liverpool, Manchester, the big cities there are being very heavily hit. So it's moving around. Southwest relatively spared so far.
Dr. Jokelainen?
Yes, I would like to just add to this that overall, all these studies are really interesting, and the data and the new knowledge they are yielding are really important, both locally for local decision making, but also exactly internationally. It's very interesting to hear from different countries, but somehow I find it very difficult to compare these studies and to take the use of the results, because exactly they are very different. It's both the sampling or the specific age groups or professions or local or larger areas, and also the tests and where in the pandemic, what's happening at the same time. So I really look forward to more and more those guidelines that are there for reporting epidemiological studies, that they would be used so that we get the basic data from these studies. They will become more comparable. So that would be very useful.
Yeah, I think you've highlighted a very important word there, guidelines. And I want to go back to Professor Martin. So we've had an increased awareness of the role of testing in the management of disease. So I think our big challenge, as it always has been, is how can the pathology and laboratory medicine community make sure that the value of testing is understood by policymakers and politicians. Because if you look at what has been happening all over the world and how the pandemic has been dealt with by different governments with the best advisors, it's still, there's been marked differences in the way they've handled it. So perhaps you can give your thoughts on that.
So I think governments generally, or certainly, well, in the UK, governments had it has a love-hate relationship with testing, because we can never give them enough. I think that's the thing. I think they've learnt to, as Mr. Kotsopoulos said earlier, they have learnt to love us a lot more, and they understand quite how vital we are. I think they ignore most of what we do. We have had instances where we've had a government minister said that the large sort of private mega labs were the equivalent of a Nissan car factory, and the NHS was the equivalent of Savile Row, which is a very sort of expensive tailors in the centre of London. And I think they probably failed to spot that we do 1.1 billion tests in the NHS. Yeah, exactly. We spend £2.2 billion a year on pathology testing. This is pre-COVID. So it has been a chance to encourage ministers and MPs much more widely across government to think about pathology. Lots of enthusiasm for reorganising everything all the time, and for rolling out testing. So we are literally, over the last 2 days, we are about to roll out lateral flow testing, which is an antigen test, the Innova, and I think the PanBio testing for all asymptomatic staff. So coming soon to a hospital, a primary care near you, is a pack of lateral flow tests that you will take home. And so the decision making is becoming, it becomes increasingly informed, and then there is a little bit of which some people might think they understand a bit more, and then they'll get over enthusiastic and want to roll something out nationally, which requires, may require a little bit more planning and qualification than is previously thought.
Sorry, Mike was off. Dr. Wright?
Yeah, it was just a question for Joe. Will positive tests be confirmed then?
Yeah, they'll be confirmed on PCR.
Yeah, that's a good development, I think.
Yes, it is a good development. It's going to be again, it's massive logistic issues, and I think when you were talking about the supplies issues, I don't think there's been a country that hasn't had supplies issues. We were told that the Mayo has got in the States has got 20 different platforms for testing, so that they can ensure that they've always got access. I don't know whether in Saudi and Denmark you've had the same issues with access, similarly in South Africa.
Can I just ask out of interest, because obviously what we're all sitting here saying is we require data to answer all these questions, and this is obviously a huge change in the UK, and the NHS is both an incredible resource for data and a slightly kind of dark ages IT environment, and I wondered whether we were going to be able to capture all the relevant data, do you think, Joe, from this laudable effort?
So I think internationally, I think the importance of data is absolutely key. Tahir showed us some excellent data earlier from South Africa. It is all being collected, and for the first time ever, we've actually, that's one of the big things of the pandemic in the UK. We joined up all our labs for COVID reporting. So we actually put, we got 96 plus 8 labs, all now connected via the National Pathology Exchange system for COVID reporting, joined up to the public health labs. And that was a major event. It would have probably taken 3 years to achieve outside the pandemic. And we did it in 3 to 4 weeks with the support of NPEX. So that was a big decision. You know, I got phoned up by the head of NHS X, which is the digital and data, and said, Joe, should we do this? And you go, absolutely, yes, please. And it happened. And that, you know, so it's given us some infrastructure for reporting. But lateral flow and point of care tests, again, you've got to retrofit all the IT to those, because there's not natural connectivity into existing data systems. I'll shut up now, please.
Thank you. Thank you, Joe. You sort of segued into another question that I had for you. Yes, so but I just want to make a comment. Our government has a slightly more nannified attitude towards taking kids home, because I think I've seen how the UK's been sending around these antibody tests to people's houses, etc. I think here in this country they want a healthcare worker to do all the tests, because it's to do with those positive tests. Now, what's the guarantee that someone who has a positive test is going to declare it and actually have a PCR test to confirm or refute whether they have it, or will they just keep quiet about it? Or, you know, I think that's a concern. But it does highlight the issue of the potential role of the college in facilitating information sharing in the pathology community, especially with regard to the effectiveness of these tests, because even the experts sometimes differ amongst themselves. I know the college has been quite active in providing sort of information to the academic community. Do you think that could be expanded, or?
So we ran information videos right at the beginning. We ran a series of webinars that ran internationally. I think we've had 20,000 hits or so on those. We've continued to run events. We had a hit and run webinar jointly yesterday with the British Infection Association, which was on lateral flow and LAMP technology, and that will go up on the website. But I think, you know, colleagues from across the world, so Professor Hajir and others will be better able to comment. But certainly, you know, being able to bring people together of this stature from across the world is something that the college is very pleased to be able to do, and very privileged to be able to do.
Yes, I agree with that. I think the Royal College has been certainly, it's to do, I think the Royal College is probably compared to, say, a lot of other colleges in highly developed countries, pathology colleges or pathology non-governmental organizations, certainly more outward looking than many countries. And I think that's a very good attribute of the Royal College of Pathologists, certainly. I think that I want to ask, change the topic slightly and ask about veterinary pathology. So Dr. Jokelainen, how do you think the pathology and laboratory medicine community can strengthen interactions or collaborations between the veterinary and human pathology? And I've got a very interesting observation, at least, to make. So we've been looking for animal models to test out these nanobodies. So we want an animal model of SARS-CoV-2. So it turns out that so if you want a mouse to get SARS-CoV-2, it's resistant to SARS-CoV-2. So you must put in the human ACE receptor. So you need to get hold of a transgenic mouse or get some virus that you can transduce the ACE2 into the mouse, and then you can have it. That gets a bit more complicated. But interestingly, apparently the Syrian hamster can be infected with SARS-CoV-2 and develops the pathology that's very similar to the human COVID-19. So it actually seems to be a much easier way to have an animal model. And yeah, so that I just wanted to make that comment before you go on.
Thank you. That's actually, I'm very happy that we take this discussion also that way, because widening the networks, I would certainly welcome more collaboration between the human pathology and veterinary pathology. So I have myself kind of worked a little bit with both, collaborated with both sides because I work with zoonoses, so it's quite obvious. I think one point is animal models. That's a very clear one, but also overall just comparative pathology. Even for those hosts that are, for example, have totally a different disease from the same pathogen or something, that could be really giving us important information. What are we dealing with when we have a new pathogen like this one? And I would also say another thing is the collaboration in terms of something new or unexpected, because maybe on the other side, they have already seen something similar or so on. So how is our early, when we notice something interesting, do we discuss across these silos of are we a veterinary or human medical pathology? So I would welcome this, more of this. Yes, please. I don't know if others have comments. How much do you others work across these silos?
I'll just pick that one up. We've so you'd be amazed at the discussion of the mustelids that we had at a senior medical, all the professors of all the different royal colleges, and the chief medical officer of the national medical director, talking about mink and weasels and stoats and other members of the mustelid family. We didn't, Professor Hajir, we didn't get around to pangolins, but I'm sure the general public now knows what a pangolin looks like, and hopefully, you know, one of the few upsides of the COVID will be that people will stop smuggling pangolins, hopefully. But the weasel family and the mustelids really, you know, it has been talked about a lot. So yeah, and we've been using ferrets for flu studies for years. So one of the few good models for flu virus, and it turns out that perhaps mink or even ferrets may be the same, but the risks have been talked about quite considerably about animal reservoirs and what happened in Denmark over the mink farms.
Yeah.
Yes, go ahead.
Yeah, I would continue on that one thing I would think, like, this pandemic is mainly human-to-human transmission, and it's mainly on the human side. But I had on my talk earlier today as the final question that what if the next pandemic or some other crisis, actually, what if the animal side is more important there, or the One Health approach is more needed? So it would be really good to have those contacts beforehand, and then we can turn to each other and ask, have you seen this, and what is this new disease, or so on. So I think that would be very useful for preparedness.
Thank you. Just on the issue of, so we had a brief discussion about the impact on lab testing in general, and I think I want to pick up on particularly on hematology, and certainly to ask Dr. Wright what the impact has been on patients with, for example, sickle cell anemia and thalassemia, and whether that's, what impact has COVID had.
Yeah, of course, two very important global diseases, though many Western countries and Northern Hemisphere countries have significant populations as well. And it's so I suppose the sickle cell population. So in the UK, I think we've been very lucky once again with our kind of networked, kind of joined up approach to healthcare, that we've been able to collect pretty much certainly the whole English experience of COVID in sickle cell patients. And there are about 300 cases now, which have been proven. And it looks, perhaps not surprisingly, like the mortality risk is increased in these patients. They do have a complex sort of immunocompromised state that is not just hyposplenic, that isn't completely understood, and they do obviously have other comorbidities and other physiological frailties which you might imagine would cause problems. And sure enough, in adults, it looks like the mortality rate is about 8 or 9%. And that's been sort of echoed by studies both in the States and less so in a French study as well. The French study was predominantly children, larger population of children. So it looks like, so in terms of what to do about patients with sickle cell, at least, I think we are largely taking the national line that children should continue to be educated and their risks are small. It's a bit more variable in adults. A lot of the same risk factors apply to sickle cell that apply to the general population: age, obesity, comorbidities. And so those patients, the older patients, look like they do a lot worse than the younger patients. So advice being given accordingly, really. Thalassemia, we have a smaller population in the UK, and there's not really a great deal of evidence to say much at the moment. I think one of the big things for thalassemia worldwide has been the effect of blood stocks. So, I was talking to a colleague in Bangladesh who was explaining to me that really a lot of their blood donation arrangements have sort of almost collapsed with this. So there've been huge difficulties getting blood stocks maintained, not just for thalassememic patients and not just in Bangladesh, obviously, but in many developing countries. Though I know in this country we've largely maintained adequate blood stocks throughout, thanks to sort of considerable efforts from NHS blood and transplant. Does that answer the question?
Thank you. It actually raises another question that I had, but I see we have a couple of comments and questions in the question and answer chat box, and I'll come to those in a second. And just to for the attendees, if you have any questions, please type them in the question and answer box, and we'll put them to the panelists. But I had a question about the use of plasma therapy, and I wanted to get an idea of how much the plasma from one person, assuming that they've got a good titer of antibodies, how many people can that be used for once it's harvested? Do you have any idea? Is that a silly question, or I don't know?
Is that a question for me?
Yes.
I was desperately hoping it wasn't.
I was trying to.
I'm not sure I can answer it, I'm afraid. I know that I know that passive immune transfer is being looked at, and I know that the NHS blood and transplant have been doing quite a lot of work on this, but I'm afraid I'm not familiar with the details. There is the commercial product that got used on Donald Trump, isn't there? I don't know quite what the nature.
I was just curious how. It's in the cost effectiveness. If it's one person being used to treat 5 people, or is one person, or is it the other way around? 5 people.
I mean, these are usually have to be vast pooled collections, don't they? I think. So I'm not sure how far that has progressed. I'm afraid. I don't know if anybody else can comment.
Yeah. So my understanding is that one collection treats. It's I think it's being used on a 1-to-1 basis, and it's depending on the titer of the antibodies. The person who knows all about this is Dave Roberts, who's heading up all the UK trials. So do get in touch with him. He's the Blood Transfusion Society and also college research lead as well. He's incredibly knowledgeable over the convalescent plasma. Even our Secretary of State for Health has donated plasma for the convalescent studies and treatment. Yeah, it's been used. It is being used.
Okay, I'm going to cross over to the questions from the attendees. So we've had at least a comment about professional sports using precious lab resources that could be used for healthcare priorities. So I don't know if you want to comment on that.
Is that a question to me? Probably.
Well, yeah, if you have any response.
It's a thorny question, but it's a good question. I think it's an appropriate question. We've asked it many times. It's been debated heavily. And I think I mentioned this in the talk this morning. We always made it very, very clear that if there is capacity left at the end of the day, we are very happy, in fact, to use it for professional sports, for workplace testing, for cultural institutions. Why not? If it's not, then they have to wait. And that has been accepted. It's even written down in contracts. And the same is the feedback. It's identical to what we tell cruise lines who want the passengers tested and others. And it is a bit different now, having gone through summer and late summer, where let's say the burden on the labs had eased a little bit, and we were more able to do these kind of programs. So we don't think testing people in professional sports is a bad or ethically strange thing. It becomes tricky, let's say, when capacity is utilized more fully, and for that we have a very, very clear position. Now, in terms of the absolute numbers, the testing which is used for sports here is about 0.4% of the actual daily and weekly testing. So in absolute numbers, it is such a small part that you have labs who on a Friday evening do 30, 40 tests for Bayern Munich or Borussia Dortmund, but that comes on 3,000 or 4,000 tests they do in 24 hours. So as long as that ratio is okay, actually we don't feel bad about doing it at all.
Joe?
Sorry to come back again, but so one of the real debates through this whole pandemic has been the balance between economic damage and damage from COVID. And one of the things that professional sport and certain other testing has allowed is actually, there's what, 32 million or billion pounds worth in professional football. Okay, a lot of it goes to the football players, but actually in terms of the advertising, the knock-on effects on global economy, of shutting down businesses like football, it is actually considerable. It employs a huge amount of people, and this has been a constant debate. We know that in poor economic circumstances, it's the poor, it widens any damage to the economy, widens equality gaps. It's more damaging to poorer communities, and the more economic activity we can get going back, then the less likely that health impact on our communities will be. And so that's one of the arguments for testing in sports and wider communities. I think you've seen it across the Middle East as well, Professor Hajir. So that's the economic balance. But I agree. I think your ethical position on testing. So I know that you shut down private individual testing to preserve health service testing, which was a great credit to your organisation at the beginning.
Professor Hajir, you had your hand up.
Yes, please. I believe as long as patient testing is not compromised and you are offering your test for your patients, why not to offer it to other parts of the economy? Because definitely COVID is affecting every aspect of our economy, every aspect of our lives. And you cannot keep the whole country under lockdown. So many businesses affected, so many economic disaster happened, and that, as Professor Joe just suggested, that the effect is mainly or will reflect on the weaker sort of part of the society, on those who are waiting or who depend on their monthly salary or on their daily job to do. And definitely sport supports so many different categories of our economy in our daily life. Just to go back to the testing issue, I want to just share with you some information that we sort of came through across it during the COVID phase at the beginning. We had our first wave, and that was so strong. But now we are past that, and I'm not sure whether we are going to go through the second wave or not. But during the peak of the first wave, interesting enough, we could not get any test from the big companies, the Swiss and American companies. And we had to have our top politicians interfere with governments like Switzerland and US, asking them to support us with certain kits. While we were going through that sort of dilemma, for the first time, we saw Russian companies, Korean companies, Chinese companies coming through and offering their kits and their tests, companies that we have never heard of. And that is interesting. So at the end of the day, what we did in our own hospital, we decided to develop our own RT-PCR kit. And what we did, we sort of synthesized those primers and probes, and we got enough for many hundreds of thousands of tests, keeping it in the freezer. And meanwhile, we are utilizing the commercially available kits just in case. We will take those out and use them. And I believe that countries like in developing or underdeveloped countries, people should really think of ways to find or make available certain alternatives to commercially available kits.
Yeah, I agree with you there. I think yes, so, well, sometimes the homemade stuff works better than the commercial kits. I think I concur with Evangelos about the testing. Yeah, we found that, okay, so very early on in the pandemic, there was a shortage of tests, so the tests were prioritized. So there's been a lot of investment in setting up the analyzers and the machinery to do all the tests. So, so things have certainly changed. And I think right now, for many countries, the testing capacity, because a lot of countries have gone through the worst, the testing capacity is far in excess of what is required. So there's certainly with the issue about using lab resources for sports isn't really such a problem, because there's plenty of capacity now, because I think the whole the capacity across the world is much better than it was, certainly for dealing with this kind of thing. So I don't, I certainly concur with you. We've got I think about 5 or 6 minutes just to tackle some of the questions from the Q&A. There was one question about whether, how does one determine in antibody testing, how does one know whether samples are being sent for surveillance or for curiosity? And is there a way to determine this on the request form and then to prioritize the test? Perhaps I could ask first Evangelos and then Professor Ali.
It's very hard here, Professor, to do this, because when the specimen comes through a doctor's office, it doesn't say on the tube whether this was a curious patient or whether it's, as we say here, a curative case. And it has billing implications and all kinds of things down the track. So it's hard, but to be perfectly honest, we are not faced with an avalanche here of these type of tests. So the lab just deals with it. This is testing which also scales easy, much easier, of course, than PCR testing. And so it simply hasn't been a concern. We are supporting multiple studies from the large research groups here in Germany who do large population studies, and that is just kept completely separate. It is funded separately. It goes through a different stream, sometimes through different labs, and is reported differently. But in the general population, when it comes through from a GP's office, it's very hard to ask the tube, are you coming here for curiosity?
Professor Ali, did you have anything?
It's very difficult, as Evangelist suggested, very difficult to tell. But what we did in our hospital, we are a tertiary care hospital. We restricted the test only to ID doctors.
Yeah, I think that's one way of doing that. Yeah, a question here about with regard to the information sharing. Do any of you know of examples where governments have helped or hindered the sharing of knowledge?
I think I mean, we can only go country by country in our experience, but for the example here, our experience has been more on the positive side. So the government here, the Robert Koch Institute, that's the national sort of research institution and as a central lab, was asked to bring together a standing group of experts, which has government people around the table, scientists, researchers, lab people like us. There's even a representative of the diagnostics industry, the GP representatives. This group meets every week and communicates literally daily. And that information flow has, initially it was a little bit, you ask yourself, do I have time for this? But it has proven an enormously valuable resource in both directions. We are hearing early what government concerns are. So currently this is, do we offer saliva testing to the whole population? Does this make sense or not? But it's also been a good forum for us to transport information back to government and voice concerns early, for example. So one big discussion we're currently having is that scaling up testing further is very well. Indeed, like someone just said, some of the delivery and supply problems are easing a little bit, but we are now having massive staffing problems in these departments. This is a testing which does not scale easily. And even though a large part of testing goes through the large automated platforms, the Roche and the Hologics and the Abbott and all those, we are still performing a very significant number of these tests on more manual platforms with separate extraction and cycler steps. And this, with the regular testing, the non-COVID testing, back at more or less normal levels, HIV, HPV screening, many of these other things, it's a double burden on these departments. And these are very well qualified staff. We cannot just replace them with students or randomly selected lab aides. And this is a concern. We've had multiple positive cases in the labs, people quarantined. It's the time of the year here. It's 7 degrees here today, centigrade, where people naturally get sick. It's a real concern. And everybody who could remotely spell PCR on their CV has been hired in the last few months. The market is empty. There is no one there who could still be hired. And we are warning a little bit that we are stressing these people massively over many, many months now, day and night, every day, every night, every Saturday, every Sunday. And this is a bottleneck which has not been communicated so well yet. And I personally have a big concern there that if we have even more numbers of higher numbers of people falling sick, that we will not be able to report on time.
Dr. Jokelainen?
Yeah, I would like to just echo the beginning of what you mentioned, that overall it looks positive. This crisis have been bringing countries together to discuss things and share things, and also different professionals. But at the same time, many countries look quite close. They just look inside. So it's also, of course, about resources and priorities. But I would like to bring out just as a preparing for something that could happen the next pandemic, for example. So really positive example, I think, is this One Health EJP that I mentioned, where I'm privileged to be a part of. So it's a European collaboration across countries. We have 19 countries, and it's actually enlarging currently. So we will be having more countries joining, and almost 40 institutes that together are addressing One Health topics, including COVID-19 is actually one of those that there is work together. And this is interesting structure because all the institutes, when they joined, is a co-funding. So they have the EU funding from the project, but then they have their own funding. So they have a mandate from their national authority, typically a ministry, that they are supported to be participating. And I think these kind of structures are really important because they will last longer also. So within the country, the different ministries are now talking together more. And when the institutes are participating like this internationally, I feel, of course, I'm a bit biased because I'm in it, but I really think this is impressive and could be kind of a long-term established system. Yeah.
Professor Hajir will probably give you the last word as we near the end.
I would like to share with you what we did during the peak of the pandemic in Saudi Arabia in our hospital. So we were really afraid of our technologists getting sick, and then we will not be able to conduct what is necessary for the patient care. And what we did, we grouped our technologists into 3 groups, 3 shifts, especially those testing for PCR. And we made sure to leave 1 hour in between each group and to get the cleaners to clean the place and sanitize handrails and etc., including lifts and all of that. And that really gave us the privilege of going through the peak without major staff disaster. It's enough a problem to have patients, but it will add to it to have the technologist infected. So it's very important to keep your technologists safe and keep backup plans for the kits as well as for the technologists who are conducting the assays. And I believe this pandemic is teaching us great big lessons in terms of testing, which is the major issue. It is the major title of this pandemic, testing. And then all what comes with it in terms of keeping patients safe, and technologists safe in terms of keeping kits and supply going through to really cater for our patients. Thank you.
Thank you very much. We haven't exhausted the topic, but time is against us, and I'm sure we can go on for several hours discussing it. Now, I'm sorry that we've not been able to get to all the questions in the question and answer chat box. But as you know, this is how things go. This topic is vast and extensive, and the discussion has been quite detailed. I'd like to thank all the panelists for your contributions and for your fascinating thoughts on this complex problem that we're facing, the whole world is facing today. And I want to thank all the attendees for paying attention and for your questions. Again, once again, apologies that we didn't get to all of you, but as you can imagine, there's a lot that we can discuss in this. So thank you very much, and this has been a great pleasure and a very successful roundtable discussion.